statewide InterCHNA conference, building strong partnerships between hospitals and CHNA. My name is Wendy Garlic, and I'm a member of the Greater Fall River Partners for a Healthier Community, which is the Fall River CHNA. We're delighted that so many of you could come today, and we welcome members not just from CHNAs, but from hospitals and community benefits committees. And hopefully you'll find today's gathering an ideal opportunity for acquiring new knowledge, networking with new people, and creating new partnerships. Coming together as a statewide organization will enable us to learn from one another, gaining strength through collective vision, action, and knowledge. We'll begin our event with a panel discussion, and in a moment I'll introduce you to the panelists. We'll then have some time to connect regionally. Lunch will be provided through the cafeteria, and after lunch we'll be discussing advocacy, and we're delighted today to have Andrea Freeman, where's Andrea? Who is the Deputy Field Director of Mass Public Health Association, to lead us in that discussion. So now, meet our panel. So we have Lisa Wolf, who's the Director of Research and Evaluation at Health Resources in Action. We have David Aronstein, who's the Director of the Boston Alliance for Community Health and a member of CHNA 19. We have John Riordan, Director of Community Relations and Partnerships for Boston Children's Hospital, and Kerry Mello, the Community Benefits Manager for South Coast Health Systems. So welcome our panel, please. What are ways that have worked for your hospital to connect with CHNAs and other community coalitions beyond funding opportunities?
But we have been doing our health needs assessment in concert with both CHNAs. It's actually saved us money. It's helped us reach into the community much better than if we did it ourselves, and that's been a big plus for us. So that's just one example.
In hospitals, some of the recently the funds would be directed in ways that were in keeping with where hospitals thought they should be. And I think it gave the community a sense that they were being heard in where the funds should be directed as well.
But the two sort of big areas that I see related to this question is, one is the issue of alignment. I'll be sort of saying that word a lot. Where we have seen successful cases is when hospitals are working with community groups, and while they each have their own sort of missions and agendas and areas where they want to focus, they've also found some common shared topic areas and areas for alignment, where the hospitals are providing some funding but also expertise and partnerships and support, and community groups are helping to sort of extend that work into the community on the ground, because they have the relationships with other community groups and the populations that they serve.
How do you, I think, in larger cities, how do you align the different hospitals' needs assessments? Since while they're sometimes assessing different parts of the city, there's sometimes quite a lot of overlap. So from our perspective, there's a lot of redundancy, a lot of time and effort and money going into assessment, but there are ways, I think, that it could be better coordinated and more streamlined. Lisa can give you a couple of examples of that from other cities. The joke that I often make is, those of you who are familiar with Boston know that there's the Longwood Medical area where there are 4 or 5 hospitals, and I've always joked that, if I lived on Mission Hill, I would spend my life going to focus groups led by hospitals.
I think it's important to also recognize that hospitals are operating still under proposed regulations through the IRS for their community health needs assessments, and meeting those proposed regulations are tied to 501c3 status, so it restricts to some degree hospitals to deliver on a community health needs assessment that fits within those boundaries. And it makes it very challenging, because you're having to define your service areas in a different way. You're having to meet requirements and how you collect information often in a different way than maybe you've done before. And so those restrictions or guidelines make it a little bit challenging to do what we would think of as a comprehensive community health. So I just wanted to make it, it's not an unwillingness necessarily, but there are real barriers in front of us right now until those regulations are clear and how we might move forward in a more collaborative way.
I agree with Lisa that hospitals face some barriers, but I also think there's an opportunity under the Affordable Care Act, because one of the other regulations is creating a comprehensive community action plan that has input from the community. Although that was emphasized in the AG guidelines before that, now it's really a very strong regulation. So I think that's kind of an impetus for having more dialogue than maybe we did in the past in a concerted way. I just wanted to quickly mention something that we're doing on the South Coast, and I put something in all your packets similar to what's happened in Texas. We formed what we call the South Coast Health Data Network, and we've engaged an academic partner, and that really makes a big difference. So a few of us have invested some money, and all of the focus groups and everyone in the community is doing all these kinds of things. We were sharing them, but not in a really organized way. And then we also have the perspective of the Urban Institute at UMass Dartmouth. So we're just kind of at the beginnings of all of this, but it's been helpful in writing grants, and we kind of feel like we're doing ongoing needs assessment because it's something that's continuously updated. If partners, have done something, they put it up there. So I think it's a really effective way to share data.
But it's about getting the different sides to talk to each other so that we can have some kind of measurable collective impact in that area.
And just to sort of go to your question about sort of the internal piece within the hospital, and I think this is not unique to hospitals. I think we find this in every organization, even our own, that certain offices are not always talking to each other. And many times when we're contracted by a hospital for their specific community health assessment, obviously we're doing all this work in the community, but sometimes we also use some of that effort to do a number of interviews and other kind of data collection work within the hospital, where we will talk with interpreter services and workforce development and the community benefits folks, but also the case managers and other support service offices that to ask them about what's your work in the community, what do you see as the role as a hospital, how can the hospital increase collaboration, coordination within its own institution. Because what we've been hearing from our hospital clients is we go to a community meeting and there are 2 other people from the hospital there, and I didn't even know they were coming. I didn't even know they were working in this neighborhood. And so it would be nice to have known that before we all showed up and didn't necessarily look good publicly by not knowing what the left hand, what the right hand was doing.
From the hospital's perspective, we have to respond to the IRS, which has its own set of guidelines. We have to respond to the AG, which has 8 different set of guidelines. In the city of Boston, we have to respond to the city's payment in lieu of tax agreement, which has yet a 3rd set of guidelines. And then we get to DON, which has another set of guidelines. So what we've attempted to do is try and do it all in the same way. We consult with as broad a spectrum of folks as we can. We use our community advisory board. We went, had the community advisory board go through the DON recommendation process. We then brought some of those to the CHNA. So I think the easiest, it's a system that if we were redesigning it from scratch, it wouldn't be what it is now. So I think it's confusing for both sides, and in our case, we're just trying to make the best of it by trying to be consistent in however we distribute funds.
It's kind of like the insurance system. If we were designing it from scratch, it wouldn't be the way it is.
So I'd like to thank again and show your appreciation to Carrie Mello, John Ray Horton, David Aronstein.
Well, then we have no clue. Mine took some key information. Really? Yeah, we have to focus.
Also, okay, who often feels overloaded by their obligations for work or volunteer commitments? Anybody here feel overloaded? Okay, well, one, not only do we all have a lot in common with each other, we also have a lot in common with our state elected officials. questions, they're asked to solve problems that they don't have answers to all the time, or even easy, quick access to good information or good solutions. They also are often asked to do all sorts of different things that they can't do and they're overloaded. And so I'm not trying to say, oh, those poor politicians. But I am trying to say that they're real people too, and they have a lot in common with us. And so this is the whole effort, is to point out that in communicating with them and sharing information with them, and yes, lobbying to them, they're human. You know, they're not some alien being. But so I just wanted to point that out to you, because that it's essential to keep that in mind as we think about what our role is in terms of communicating with them. Is there anybody here who is, I'm not going to ask anybody to raise their hand, but in the general population, there's a lot of people who are scared to lobby and feel like maybe they shouldn't lobby, or that it's illegal to lobby, that it's dirty. And and it's not. And in fact, it's our civic duty, honestly. It is our civic duty. And to not just advocate and educate and inform is our civic duty to lobby for our interests, especially for community-based social service organizations, health-based information. There's a lot of complex information out there. There are very few silver bullets. There's very few right or wrong. But it's our responsibility to make sure our elected officials know what we're doing, know what we've done to make our communities better, to their communities, our communities, our districts, and know what challenges we're having and know what barriers we're facing.
Gambling and predatory gambling, that we are the only public health organization in the state that took a stand on this.
Wow. Thank you. Give that man a sticker. If he doesn't already have one.
I mean, I think there's some redundancy, because I think we've talked about all four of them at one time or another, but yeah, there's a public health perspective that goes to all four of the referendum questions. Andrea just spoke about question 1, which is the gas tax initiative, and the public health vote on that is no, because it would eliminate an important revenue stream that would support infrastructure around the state and cause some real safety issues.
Including regional transit, access to public transit, all that.
Right. It would really undermine some of the improvements that were passed in the transportation improvement legislation in the last couple of years. Question 2 is the bottle bill. Public health is expanding its contacts with the environmental movement, and going green is being seen as more of a public health issue, and for reasons we just talked about. Yes, on question 2 is a public health perspective. Question 3 is the casino bill. The public health perspective on that is yes, which would repeal the casino law. And question 4 is a yes, which would support the legislation that would require employers to offer sick time to their employees. So no, yes, yes, yes.
That's good.
I'll have what he's having.
So what do you think we can do as a statewide body? Say it.
Change the determination of need process.
Okay, and how many people agree that that is something that we should be looking into?
I would also say advocating for stronger relationships between CHNAs and community benefits departments.
Great. That?
Educating the hospitals, the public about who you are and what you do.
So we had a public health commissioner years ago, John Arbeck, who was very CHNA pro, and he was very strong supporter of ours. And if we want to do anything, we need to educate that new commissioner of public health why CHNAs need to stay strong and why they're an important component of what goes on in all of our areas. So.
Can't thank you enough for putting up with this small facility and for being part of it. We hope that it was a worthwhile day. Thank you all.